Bueno, estamos acá desde el quirófano de Oftalmocórdoba, ya terminando nuestro segundo día de nuestra cuarta edición del Congreso. Quiero presentarles al doctor Ashraf Armia, que nos visita del Cairo, de Egipto. La verdad que para mí es un gran honor tenerlo hoy en nuestro Congreso. Es su primera participación en Oftalmocórdoba. El doctor Armia es un reconocido oftalmólogo, cirujano y gran amigo de la casa, que está muy involucrado en investigación, en cirugía, es un gran líder de opinión mundial y bueno, por eso es un gran honor para mí tenerlo acá. Así que bienvenido, doctor Armia. Ya puede comenzar con su presentación.
Thank you so much, Dr. Tessiano. It's a great honor to be among you all, and it's really a pleasure to be first in Argentina, maybe virtual, but maybe next time to be in person. So I'm going to share my presentation.
Muy bien, Ashraf, podés compartir tu presentación.
So when I thought about the topic of phacoemulsification, in all my career, this is the challenging point. If you start it in a best way, so you are going to end with a perfect result. Even when we train the trainee, we make the rexis the last step that they know, because if you fail to do it, you are going to lose the case. I have no financial disclosure regarding this presentation, but these are my financial disclosure. So what is the aim of my presentation? To reach the excellency in master class in challenging situation, you must know what are the rules. These rules to decrease the deterioration when a complication happens. It is not a shame that complications happen, but it is a masterclass to know how to deal with them in the most right rules. So as we start, I started as a history before we go to the what we have now. So Howard Gamble was the main one to start this CCC, which is continuous curvilinear capsulorrexis. But nowadays, in our modern cataract surgery, we put the fourth C, which is central continuous curvilinear capsulorrexis. In the past, they in intracapsular cataract extraction, they removed the whole lens to decrease the inflammation. And you put glasses with the patient, but this was all. But in modern technique, we do it in either ways to remove the anterior capsule, which is the capsulorrexis. It was like this. Either it was can opener when we were using the extracapsular cataract extraction, or using the forceps to do it continuous curvilinear capsulorrexis when we do the phacoemulsification. So the usual method is to use the same bent needle to begin a tear in the capsule and then guided by the edge with the around the anterior surface, either with the same needle or using the forceps. And there is both advantage and disadvantage to both procedures. But in children, often the anterior and the posterior capsulorrexis is made, since the posterior capsule becomes cloudy and early in childhood. And by using the YAG, when the child is little bit adult, we can open the posterior capsular ossification, or we were from the start doing the posterior capsulorrexis, and we don't worry about the vitreous, because the vitreous is not liquefied, and you can perform a good posterior capsulorrexis as we are going to see in the videos, and then a proper anterior vitrectomy to decrease the cells migration over the anterior surface of the vitreous or the glaucoma that can happen in child. So what is the perfect anterior capsulorrexis? Getting the right shape, the right size for optimal outcomes. Continuous curvilinear, central, as I say, this is the 4C it must be in all modern cataract surgery. You cannot do it decentered either when you are using premium multifocal IOLs or premium toric IOLs. The capsulorhexis should be central. A correct size, not small, not large, and well-centered capsulorhexis with 60 degrees, 360 degrees overlapping the capsular edge to prevent the IOL tilt or the myopic shift or the optic decentration and the posterior and the anterior capsule ossification, partly due to the combination of the systemic symmetrical contractile forces of the capsular bag and the shrink wrap effect. Very important, before doing the rexus, the surgeon must place enough viscoelastic. Usually in my way, either you put a visco, or if you don't have, you can put a visco-cohesive, but don't overexert the anterior chamber with visco-cohesive, because it can make the capsule going back and you are not going to control your capsulorhexis. This flattening by the visco-cohesive of the anterior lenticular capsule prevent the forward push of the lens by the vitreous pressure, which can result in radial tear if you didn't control the pressure during your capsulorhexis, as it happens in the white cataract with hypermature, or in infants, or doing in pediatric cataract, and as we are going to see in the videos. So all my presentations is a video-based education part. So this is how this is normal. What we do for a classic rexus, we fill our viscoelastic. You can see the edge of the visco-cohesive. First, I do a snip with the capsulorhexis, and you can see that my rexus is has a serrated edges to see the diameter of the capsulorhexis. So you first do this opening, then you can see I am lifting to do the C. This lift is very important because when you lift, you are going to hold, and I usually do it in 4 steps with the forceps, 4 quadrants, and always make your rexus when you hold it like this, as I'm doing with the mouth, like this to the center. Because if you do the flap like this, it does not going to extend. And then I hold. Then the same way, controlling the way, then 4th stop, and you make the flap to the center, hold the flap to the center all, and then the 3rd and stop. This is take care. This is the most difficult part, because the visco, it's sometimes the visco cohesive go out at this point, and this edge you can lost from the field. So you always tell your assistant or the nurse to wash it to see the rexus, the edge of the rexus. Very important. Then we continued and we reach the good size of the rexus, as I am put it in the animation here. So this is the normal. This is the classic one, and this is the usually the straightforward sequence. But we have a lot of cases that we have it challenging in our capsulorhexis. The pediatric capsulorhexis, the white cataract, extended capsulorhexis, how we manage, fibrosed capsule, Morgagnian cataract, uveitic cataract, and what if PCR posterior rexus happens? Because I'm going to manage both the anterior and the posterior capsule. I'm going to make it seen in all videos I'm going to present. So first, we're going to start with the pediatric cataract, which is one of the most challenging capsulorhexis. Very important, see, to inflate the bag very well with your visco cohesive. Then, capsules of the pediatric are very elastic. You cannot open it with the capsulorhexis. So with the needle, not bended needle, straightforward insulin syringe, you just go make your open, elevate the edge, and then stop. Because if you didn't stop, you're going to extend. Then with the capsulorrexis, see what I'm doing? I am pushing, I am holding, pushing to the center. And when I push to the center, the capsulorrexis is going to continue because it is ripping and shearing. See, I am hold, just rip, shear, then rip. See, and you continue to reach. When we reach this part, you push to the center. You hold your axis, the edge, and push to the center. Very important in children to see. See, I am stopped. When I feel it is more extended, I push more to the center to control it. And you can see now how it made it a very good size, because this is a pediatric cataract, and the rexus does not, it's very important, not small, because small we're going to lead to phimosis, and large we're going to have the IOL captured. So very important to have a good size to decrease the reaction between your iris tissue and the anterior edge of the capsule, because this is the area where the posterior synechia can happen in children. Okay, what about white cataract? It's not an easy. White cataract, usually we do stain, but I'm going to tell some tricks. To have a complete bubble in the anterior chamber, you should evacuate all your aqueous from the anterior chamber. Don't put the air while the anterior chamber is full of aqueous. The bubble always is going to be small. And you can see now, I am doing the bubble, full bubble. Full bubble means there is no aqueous in the anterior chamber. Then you stain your anterior capsule. At this point, very important, see what I'm doing now. When you inject your visco cohesive and you put an air, what you are doing to do? You do what? See, the cannula here behind the bubble, injecting and pushing the air away. This means that you are pushing the air and inflating all the bag, inflating all the anterior chamber. My technique in all white cataract is the spiral rexus cataract. How you do it? Don't aim for big rexus from the start. You can do it like an onion shell, small, medium, and large. You can see it now. I hold, always small, and always to the center. See, I'm taking the flap to the center. This is the finish the small, starting the medium, holding to the center. Take your time. See how I'm sweeping. This is very important. Take your flap to the center till you finish it. You are closing from outside to inside. See, I'm increasing little by bit like an onion. It's the spiral rexus. You reach the size you wanted, not from the first shot, because sometimes in white cataract, it can extend easily due to the milky fluid extending the bag from inside. What about if the rexus extends? This can happen very easily, even in highly experienced surgeon, because he lost the concentration for 1 second. Can see, when you dilate the pupil very much like this, you can see the zonules here, zonules here. When you reach the zonule, this is the volt going to decrease. And this is the area where you can lose your rexus if you reach this point. You can see now. So I'm starting as normal, the rexus, elevating the flap as I'm usually doing. I'm doing in very small, in a very slow motion now. See, I lost the concentration in 1 second. Left, see, oh, stop. This is what happened. What happened to me that I reach here, I didn't stop, And always, also we did push to the center, so it extends to the periphery. See? Oh, at this point, what you are going to do? See, this is the point, and see, this is a news, and this is the size of the rexus. You should stop. You should stop here and continue like this. But you extend the rexus to reaching the news. This is the danger zone. If you continue, you are going to lose your anterior capsule. So you should stop and hold from the end, from this point, and make a force like this, radial, direct radial, to redirect the force to continue in the right position. You can see it now. I am holding, radial, see, redirecting and redirecting. If I didn't see this when I am doing, I was going to lose my anterior capsule. And you continue as normal. What about fibrosed rexus? When you see like, when you face case like this, you should start thinking. We did the stain, and after the stain, we found that we have a ridges here, and this is areas of sub-anterior capsule fibrosis. There is fibrosis here, and a lot of fibrosis here. This area is okay, this area is okay, but this fibrous tissue extending nearly away, so this will be a critical zone. So what we can do, we are going to start with the needle first to see how we are going to start. It's a bended needle. You open, and you can feel it is a capsule blended with subcapsular fibrosis. All you can do is trying to separate the anterior capsule from the subcapsular fibrosis. Slowly, take your time. Don't be hurry in these cases, because this is not a normal case. This is a challenging situation that you are going to manage. So take your time. I'm continuing with the needle because I want to see how it's going to do after. I'm separating, like sharing. I'm separating the anterior capsule from the lens, as you said. And at this point, I felt that I cannot do anything. So with the micro scissor, I make a snip for the rexus to redirect it again. And you can see it now, how I'm going to handle it. Because you need, at the end, at least continuous edges. But I made some radial tears. So what I'm thought now, that I'm going to remove the central subfibrosis with the capsule, and then trying to do another rexus outside this zone. This is what I'm aiming now. So the most important is to remove this part first, as I am doing in a very slow motion. You can see it. I succeeded to remove the area central, the anterior capsule with the subretinal, subcapsular fibrosis. Okay, then with the capsulorrexis, I'm trying again to start a new rexus. It's a new rexus outside the zone where I made radial tears. But see, it's highly fibrosed, and I am traction little bit, so can manipulate your anterior capsule still very slowly because you are traction on the sinews, but you can do it. It's very easy, and you can reach at least and this area with removing, as you see, removing the subretinal fibrosis. See, I'm removing also, and I made it another one, and I reached nearly a continuous point. This is another case of the same. Also, fibrosed anterior capsule. I started with the capsulorrexis. This area is the critical part. This is the area where the wrinkling and where the subretinal fibrosis. So I stopped here. I make it away. So I make it like this, away from the area. I didn't try here. And I'm trying to manipulate very slowly my rexus to start a point where this is a capsule with subcapsular fibrosis, and I'm going to bypass this area. Always make this flap in the center. This will prevent the extension of the capsule. So I'm bypassing the fibrous part. See, this is a capsule with fibrosis under the anterior capsule. And I'm removing in block the anterior and the sub-anterior capsule fibrosis, as you can see. And I stop at this point, and I continued with scissor. You can see it now. Because at this point, I felt that I can't, so I stopped. This is a flap, so I took a snip and continued in the other way. So I reached at the end, continuous part of my capsulorrexis. It is not central, but it is continuous. So what about Morgagnian? It's a challenging case. Very important in Morgagnian to, as I'm doing now, you put the needle and aspirating as much as you can the fluid, and you are going to face a very small nucleus. See, very small nucleus. To do your good rexus, inflate the bag again with visco-cohesive, as there is a bag full of extended. And then you continue the rexus as normal, but take care in these cases, the venules are very weak, and always try to make it slowly, because all this, the bag has, the venules are very weak because you don't have enough support between the traction and the traction of the venules, but you can do it in the end. What about areas where there is posterior synechiae like this? Very important to remove all your synechiae. I'm going to bypass this. So let you see how it is after I removed all the posterior synechiae. I put my Malugan ring, because you need in these uveitic cataracts a very good size of the rexus. But in Bishop disease, which is one of the challenging uveitic cases, usually there is a problem in the anterior capsule, a lot of fibrosis like this. So very difficult. So I didn't manage with the rexus. So I started with the needle again. And very important, when you do your rexus in these cases, take care, every ridge of this is a site of radial extension. So always your eyes, when you're doing the rexus on this edge, when you reach, take care, slowly stop and manipulate your continuing rexus. Look at every edge of this, because this is an area where it is very easy to extend, and you stop at every edge and try to redirect your force to complete your rexus in the best way and best size. What about posterior rexus in children? It has a technique which I'm going to show it now. When you do a posterior rexus, you inflate your bag. Then with the needle, you are going to make a small opening here. You are going to see it, small opening. Then after this, with your visco dispersive, you go under the posterior capsule and you are going to see the wave, how I'm separating the posterior capsule from the anterior vitreous face in the Berger space. See, you can see the wave of the visco dispersive. And you catch your rexus and you try to manipulate it in a fashion like you are doing your anterior rexus, and you are going to succeed as it is the anterior rexus here and the posterior rexus here. What about my last case is PC tear happened due to my fault. This is my fault from the start. First, the anesthesia was not good. So you can see the eye is up. It's very good. Even during the keratome and the MVR, I am pushing the eye is pushed up. This is my mistake because I started rapidly before the anesthesia gets the eye central. This is the first mistake. The second mistake, that I was temporal while the eye is up. This is another mistake. After I remove, so when the eye is up, you are going to lose the anterior chamber during your IA. And this is what happens. You are going to see now, you are going to see, I'm doing my anterior rexus, the removal of the cortex. And at this time, I didn't concentrate. Oops, I got a tear. You can see the tear. So when you got the tear, the first step, don't go out. Because if you go out, you are going to lose the pressure of the anterior chamber and the vitreous will going to come up from this opening and it's going to extend, you are not going to control. So what I'm doing now is removing my aspiration, putting my visco dispersive, inflating the bag. This is the most important. And thinking how I'm going to do with this tear. There is no vitreous at all now. So what I am doing now is, with the rexus, you are going to see, putting the visco cohesive to maintain the pressure. And with the rexus, I am going to continue to complete this opening in a complete posterior capsulorrexis, fashioning in the same way I am doing my anterior rexus, always to the center, continuous, pulling to the center, pulling to the center. Then I succeeded to make a good posterior capsulorrexis, and then I make a dry aspiration of this remnant of the cortex. There is no vitreous at all till now. Then I enlarge it because I'm going to put a 3-piece IOL, sensor 3-piece from J&J, inflating the sulcus. And you are going to see how I'm going to manage. Then put my 3-piece IOL inside the sulcus with pushing the lens back to do a posterior capsular capture, anterior capsular capture. So the optic is captured in the anterior rexus, and we have a very nice posterior capsulorrexis. So we converted the tear to complete posterior capsulorrexis. So my home take message in this, very important to keep the bag. The bag is the normal site for any IOL. Don't lose your bag easily. The best anatomical physiological place is for PCO is the bag. So do not lose the posterior capsule easily. To do this technique, you should have a good microscope, which is I'm using. This is my microscope, the Zeiss Lumira 700, which is for me the best high resolution, high magnification when you want to do a very neat surgery. Good instrument with a plenty of viscoelastic dispersive type, good amount of patients and still functioning coronaries for sure. Thank you so much for listening and happy to be among you all. Thank you so much.
Muchas gracias, Ashraf. La verdad que una presentación espectacular, como para tenerla en la biblioteca de cada una de nuestras clínicas y presentársela a todos los oftalmólogos jóvenes que quieren empezar a operar, a nuestros residentes y fellows. Te agradezco mucho tu presentación y por una cuestión de tiempo vamos a seguir con el siguiente módulo.